We're looking at part 6 now of blood vessels on page 708, and we're considering all of the relationships regarding blood pressure of kidney, heart, and all of the interventions that occur. And we had just noticed about some things from ADH, the effects of ADH on decreased urine formation, increased blood volume, because we're retaining the whole point of the kidneys and the ADH function is to reclaim blood volume from the forming urine, and this helps us maintain mean arterial pressure. Over here we're looking at a decrease in sodium, an increase in potassium, and a decrease in arterial blood pressure. I've had to annotate this because these are also a decrease in sodium has similar results as a decrease in arterial pressure. Okay, and we noted that we had inhibition of the baroreceptors, increased sympathetic activity, release of renin. I noted to you that the liver has this dissolved protein that it's produced called angiotensinogen that gets activated by the renin, and now we have angiotensin 1, which gets activated to angiotensin 2 by the angiotensin converting enzyme ACE at the lungs. Okay, so that's something that passes by there. And then we get all the effects of angiotensin 2. We want to take a look at that. And in many cases, I've just mentioned to you in the previous part that there's something called ACE2, which has the opposite effect of this ACE1, which is to say it turns off many of the effects of angiotensinogen, especially when the immune system and sensitivity to disease is causing some problems. Right, so people who might have an infection but who don't respond to it except in subclinical ways means that they have this ACE2 molecule in conjunction with nitric oxide, and they're able to stabilize their physiology amidst the attempts of, shall we say, T helper activation, B cell activation, T cytotoxic cell activation, and then the B cell becoming a plasma cell and producing humoral immunity through the immunoglobulin cascade. Okay, so over here we have the release of aldosterone, and there is a saying in physiology that angiotensin 2 has the most to say about aldosterone. Okay, and we're going to reabsorb sodium by the kidneys, and water hopefully will follow the presence of sodium, making things more tonic. ADH is there to create aquaporins so that water is reabsorbed and it is essentially following the sodium tonicity. Thirst hopefully is one of the characteristics of hypothalamic set points. It works only modestly in humans, but nevertheless it's there. And so one seeks water. And then ultimately over here we have vasoconstriction peripherally through the arterioles. That's a key feature of the angiotensin 2. And there are other molecules of inflammation that are at play here, from leukotrienes to prostaglandins of all sorts, and pain molecules, kinins, and so on. But anyways, those are, how shall I say, mitigated or regulated by other parts of the immune system, including ACE2 proteins on, and also, how shall I say, endothelial nitric oxide synthase is also going to play a role in all of that. So hopefully if one is fit and athletic and well slept and well nourished, then one is able to endure all of this, and we have an increased mean arterial blood pressure. Okay, and I'm posing this in the time of COVID-19 for those who are listening or observing this video in some future, a year from now. This is being made in 2020, and we're enduring a pandemic. Okay, now we're over on page 709, and we're looking at yet another diagram that we're going to attempt to increase mean arterial blood pressure. And we have some factors up here at the beginning. We have increased activity of the muscular pump. We have a release of ANP. We have fluid loss from hemorrhage. So there's quite a bit of factors here that could bring about alterations. So crisis stressors could increase blood pressure. Of course, fluid loss would decrease blood pressure. Crisis stressors are going to increase body temperature. Now here they're also indicating a decrease in blood pH, a decrease in oxygen, and an increase in CO2. So things are getting acidic here. And then increased vasotone. So let's bring down, go from top to bottom here, starting from the left. The increased activity of the muscular pump and respiratory pump. So this brings about an increase in venous return. Okay, another thing that will bring about increase in venous return is a release of ANP, increased conservation, or a decrease, not an increase, a decrease in ANP, indicating that it's okay for us to release renin-angiotensin-aldosterone so that we can have conservation of sodium, increased blood volume. Again, venous return is sustained. We have fluid loss from hemorrhaging. So because we have a lower blood volume and lower blood pressure, our baroreceptors are aware of it, and we activate set points in order to increase the sympathetic and peripheral resistance issues. And so the sympathetic system will increase heart rate. It will increase stroke volume. We add venous return to the increase in stroke volume and heart rate. There are other factors over here that we didn't make it over to. For instance, dehydration, dehydration, high hematocrit. We have increased blood viscosity, and so we have peripheral resistance, again adding to the increased mean arterial blood pressure. There's ways of increasing peripheral resistance, like increased blood vessel length, and so there are factors that could be indicative here. Increased body size. I was mentioning before that obesity plays a role. It's not something that can change suddenly, but nevertheless, it's a player in all of this. And then we also had increase in vasomotor tone, blood-borne chemicals. So it could be epinephrine, norepinephrine, ADH, angiotensin II, and that type of tone brings about increased peripheral resistance. So ultimately, these are all factors playing a role in the mean arterial blood pressure. Okay, so that brings us then to this diagram where we get pulse points, and there are some emergency medicine things that I want to bring up here. First of all, the most obvious pulse points that we tend to use on ourselves, it's easiest to get this pulse right here, which is the common carotid. So the common carotid artery is right next to the trachea, between the trachea and the sternocleidomastoid. Another common pulse point is here at the wrist. We have the radial artery. We usually put a stethoscope here when we're taking a blood pressure, but in fact, if you were to consider right about there, do you see where I'm pointing? It's right on the side, the medial aspect. You can actually, if you touch there on yourself and you push the muscles that are above there, the biceps and the brachialis up, you can feel the bone right there, and you can actually trap the brachial artery right there against the bone and get a pulse. And this is actually how we get pulses in the infant who technically doesn't have a neck or a wrist. And so you have to use your ingenuity and place your fingers right here on the brachium and find their pulse right there. Okay, and then these are other pulse points. This one should be displaced over this way. the artery is way over here. This is where the lymphatics are. At any rate, these are the important pulse points that you need to be thinking about. And in particular, if you come to an accident scene, I'll come back to this in a moment. I'll come back to this in just a moment.